Okay, so we'll just get started now with the second half of this event. So this is we're moving on to the debate now. So the motion in the debate is studies on hysteria still highly relevant to the disorder as we now know it? So conversion disorder or functional neurological symptoms. I think it is a relatively genuine question, and we have amongst clinicians in the field. I'm very happy that we've got a really good selection of speakers today. There's people from psychiatry, neurology, psychoanalysis, psychotherapy, as mentioned before. So we'll start off with the team for the motion that it is still highly relevant. And first is Professor Richard Kanaan, who's a professor of psychiatry and neuropsychiatry from Melbourne, having done his training in psychiatry at the Maudsley Hospital in southeast London, and he's an active researcher in the field, and again a sort of pioneer of actually testing a lot of the Freudian theories, which you might hear about shortly. So thank you very much, Richard, for coming.
Thanks, Tim, and thanks to the Freud Museum for inviting me to this debate today. I think it tells us something very interesting that this debate is happening at all. Freud was unarguably one of the greatest minds, one of the greatest thinkers of all time. He is by a huge margin the most highly cited psychologist ever, even though he wasn't a psychologist. And this was his seminal work, and the work on which psychoanalysis, as you've heard, is found. And yet here we are, in his house, as it were, questioning whether it's relevant today. And I think there are three reasons why we might be doing that. The first one is a simple one. It might be that this book, and it is about this book, let us remember, that this book is just wrong. Great as he was, he may have just got it wrong. However, the second reason, which argues against that, is that lots of people have said, actually, you can't know, you can't prove whether Freud's theories were right or wrong. So it may be that we just don't know, and maybe we'll never know. But there's a third reason. And that reason is that maybe Freud and his ideas about hysteria have become so unpopular, so unfashionable, that we just don't want them to be right. Maybe they're just too difficult for us to have to deal with. Because remember, this is a clinical matter. We have to talk to patients about it. And if they really don't want to hear about Freud, it may not be very fruitful for us to talk to them about it. And there is, let's be honest, a credibility problem that Freud has and hysteria has today. So I'm going to take the slightly unusual step of not talking about hysteria, at least to begin with. I'm going to talk about something which really doesn't have a credibility problem, and that's post-traumatic stress disorder, PTSD. You all know what PTSD is, I take it. First described in the Vietnam War in the 70s. Soldiers experienced traumas so horrific, so frightening, that they had symptoms for years, decades afterwards. And because they couldn't bear to think about these traumas, because they avoided them so much, they never really went away, and the symptoms stayed with them. And the treatment, as we now know, is to get them to remember those traumas vividly, with all the emotion that they should have. And once they do that, the trauma and the symptom ceases to bother them in that way, and they recover. Okay. Now, if Freud had called his book Studies in PTSD, we wouldn't be having this debate. We would be hailing him as a visionary because he presciently described both the nature and treatment of PTSD in this book. How, in response to frightening traumas, the patient would deliberately avoid thinking and feeling about them properly, and so to continue to suffer from symptoms afterwards. And how you could cure them by getting them to think about them and remember them vividly. Now he uses different terms: catharsis, not exposure; repression, not avoidance, but the model is in essence the same. But he didn't write about PTSD, he wrote about hysteria, and there are two important differences. First, the nature of the symptoms. patients then had hysterical symptoms, paralyses and seizures and so on, not flashbacks. Why? Well, honestly, we don't know. But we know that they did. As Tim showed us in his video in the First World War 100 years ago, there was an epidemic of patients who had hysterical symptoms in response to frightening traumas, the horrors of war. Nowadays, that doesn't happen, at least not commonly. People get PTSD. Though many people do get hysterical symptoms in response to car crashes and so on, in the main, people get PTSD. And honestly, we don't really know why. But it did happen. The second difference, and I think the key insight of all the insights in this remarkable book, is the nature of the traumas themselves. Freud said that even in the cases of hysteria, where there was no obvious precipitating trauma, that if you looked properly and thoroughly enough, you would find one. An intrapsychic trauma, like all traumas ultimately are. He said, in essence, that losing your partner to a divorce could be just as affecting, just as traumatic as losing them to a car crash. Now let's be absolutely clear, this model of hysteria is valid. It does work. I'll give you a real example. A patient we had with a very troubled past, and a partner who was really her salvation, but who after many years decided he couldn't take any more of the chaos in her life and told her he was leaving her. She collapsed and had a hysterical fit and had a hysterical paralysis thereafter. And this happened not the next week, not the next day, but as he told her. In that kind of case, there can be no question whatever that him telling her he was leaving her in some measure caused her to be sick, caused her to have these symptoms. Now we have, let's be honest, no idea how. We don't know what the mechanism of it was. And Freud, in this book, said he didn't know what the mechanism. He said he couldn't give you a hint of how this could happen. But it clearly did. We don't know how it happened, but we clearly know why in her case. He told her, she becomes sick. If you argue that those are a coincidence, it's a coincidence of such improbable likelihood that we can ignore it. So, we know hysteria did start with trauma in the First World War on a massive scale. We know it continues to happen with traumas of this kind today. The only question, I think, is how often does it happen? Can we say, as he argues, that there's always, or at least in the vast majority of cases, a trauma there to be found? And that is a much harder question to answer. It's easy in PTSD. The traumas or explosions, car crashes, etc., that are sort of public events, and the patient responds to them in a clearly related way. They have flashbacks or nightmares about the trauma. There's no question about what's happening. None of these are at all obvious in many of the cases that we see in in hysteria. We're talking about emotional traumas and rejections that in theory would happen maybe to anyone. How do we know that these are relevant? How do we know that they happened? It's much more difficult, but it's not impossible. So let me give you another example. A patient is sexually abused as a child. After 20 years, by chance, they run into their childhood abuser in a supermarket. Now, I take it that it's immediately obvious to everyone here that that's going to be a profoundly traumatic experience. But how would you find out about that? Because on the face of it, all that has happened is she has met someone in a supermarket. Meeting someone in a supermarket is not, on the face of it, a trauma. It's not even really an event. There's no checklist that I could compile that would include meeting people in a supermarket as a sort of thing that you would want to check whether someone had had. But once you know the context, once you know that this is someone who abused her as a child, it's immediately clear to everyone that this is going to be of profound significance. And that's again as it should be. Freud said, as we've heard, that these connections were not mysterious or esoteric. They're the kind of things that you read about and understand in short stories. It's immediately obvious to all that this is going to profoundly affect you. So how do you find out about this kind of thing, the context, in a scientific or systematic way? Because that's what we have to do if we're going to show that these affect everyone, or at least almost everyone. It is very hard. It's exhaustive work. It's exhausting work. To find out the context takes hours. You have to make sure you've got a similar group to compare them to from equally difficult backgrounds. You've got to make sure that the people who are assessing these things are blinded in some way. You have to make sure that people assessing them are not the same people who are interviewing the patients, because that would bias them. You have to make sure there's more than one person making the judgments about it, so it's not just one person's opinion. All of this takes days, as opposed to some list where you just say, have you been in a car crash, have you lost any loved ones, and so on. It's really, really hard work, but you can do it. And when you do it in that way, what you find is abundantly clear. It's not that patients with hysteria have more car crashes than people from similar backgrounds. It's that when you find out the traumas that they had immediately before they got sick, that they're the kind of things that in their context would make someone get these symptoms. Okay. Do we find it in every case? No. Even with this painstaking approach, not everyone, but the vast majority of cases of hysteria have a trauma like this when you look for it in that way, and almost nobody who doesn't have hysteria does. Does that mean you have to treat the trauma to get them better? No, again, you don't. There's all sorts of ways in which you can treat people with trauma, and I'm sure we'll hear about some of those today. You don't have to treat PTSD by treating the trauma. You can give them an antidepressant, and that'll settle down their anxiety and their depression, and they'll feel a bit better, maybe a lot better. But that doesn't mean that trauma isn't the key to PTSD or the best way of treating it, just as it doesn't mean it's the key to hysteria or the best way of treating it. Now, I've talked a little bit about research today and how that has argued for the link. So I want you to think about that as we hear about the talks coming. We've got a way of thinking about how we might identify these traumas in relation to the context of the individual patient. And when we think about what we discuss for the rest of today, let's ask ourselves, are we saying that we think this is wrong, that it hasn't been proven, or just that it is unpopular or difficult? Because I put it to you, that's not a good reason to reject the validity of this book or this motion. Thank you.
Thank you. So what we'll do is we'll have all the four speakers, and then we'll have time for questions before each of the proposers and those against will quickly summarise their arguments. So the next person to give a talk is Professor Mark Edwards. He's a Professor of Neurology, recently appointed at St George's in London, having previously worked for over a decade at the National Hospital for Neurology at Queen Square. And he is one of the world's foremost researchers in the field of functional neurological symptoms, and we're very grateful that Mark can come in today to talk to us. Thank you very much, and also coming to join the against team in this setting is very great.
I see there's a scarecrow, or at least I hope it's a scarecrow out there, or perhaps the last person who decided to say that Freud was wrong and came to talk. So it's nice to be here, and much as I admire Richard's work, I'm going to say that he's wrong. So I think it's important to frame the debate properly, and coming back to one of the questions from the audience before about the sort of free-flowing idea of hysteria, I just want to say that what we're talking about in this debate is something that's quite concrete in terms of, the diagnosis in particular. So we're talking about a group of patients where it's possible not to say, oh, you don't have a neurological disease because your MRI scan's normal, but that there are particular things that happen, there are particular features of symptoms and clinical signs which says it is something which you can define and which you can study as well. And those symptoms are saying something about the mechanism. So it's not a mystery, if you like, about what is going on in terms of the mechanism of these symptoms. So just for an example, if you take somebody who has a functional tremor has particular characteristics. Has a characteristic where if you distract the patient, if you get them to do something with their other hand, the tremor stops. It changes completely. And we had an example from Tim before about Hoover's sign, where somebody says they have a weak leg. I mean, I believe they really have a weak leg. And when you ask them to move it, it can't move. But when you get that same movement to happen in a more automatic way, without attention, then suddenly it's moving again. So that's fantastically useful in diagnosis. That person doesn't need 17 MRI scans. They probably need one MRI scan. So there's a diagnostic point. But also, it's telling you something about the mechanism. It's telling you how important it is whether somebody's attending towards their movement or not. So these are things which are positively different from other neurological conditions. And it suggests a mechanism about attention and about, as Tim was talking about before, about belief, about how the symptoms and the things that people experience are moulded by their ideas, their perception of what it might be like to have, say, a balance disturbance or to have a particular type of sensation disturbance. But that diagnosis, which we can make with good sensitivity and specificity and which is stable over time, does not require the presence of psychopathology. So you do not make the diagnosis on the fact that the patient has had a trauma or not, or is depressed or not, or has a personality disorder or not. If you do that, you routinely get the diagnosis wrong. Because there are many, many people who have suffered trauma, who have severe psychopathology, who do not have these symptoms. So they are something in and of themselves. I'll come back to that in a little bit. So, I mean, Richard, not to be mean, but Richard was arguing a little bit, sort of arguing by anecdote is a dangerous thing to do. And the study to which Richard was referring, even doing a very sort of in-depth study of life events, is in a relatively small group of people and a highly selected group of people. I think it's notable that about 2% to 5% of these patients are referred to psychiatrists. So that means 95+% are not. They're seen in general neurological practice, generally dealt with extremely badly, but that's where they are. And so the full range, the full diversity of these patients is often not recognised. I think my fundamental issue with the book and the way that that's influenced, maybe a particular simplistic interpretation of that book has influenced things, is it's fundamentally confusing risk factors with cause. And that's a very, very dangerous thing to do. I mean, to me, it's similar to having somebody who has a stroke, and the doctor might say, "Oh, Mr. Jones, I'm very sorry you've had a stroke. It's bad. But if only you'd stopped smoking, I think we'd probably get you all better." "Oh, I don't smoke." "I think you'll find you do." Actually, I don't smoke, and actually I'm getting quite angry at this. I hear your anger, but I understand it's the repressed memory of all of those cigarettes you've been smoking. I'm going to go and find another doctor. See, it's abnormal illness behaviour. So it's, and if we just take that example, I'm being, but if we take that example a little bit further, if that person did smoke, then smoking doesn't tell you all you need to know about how to treat somebody who's had a stroke. It tells you something about it. It might form a part of treatment or an aspect of treatment. It doesn't tell you about everything. So there's this issue about arguing about from risk factors to mechanism, which is completely topsy-turvy from any other condition you want to talk about. So in most medical practice, we're very happy to say that we don't really know why things happen. So if somebody with MS says, "Why do I have MS?" that's a very reasonable question. But the answer is, we don't really know. There's probably lots of different causes in different people. There's risk factors we know about, risk factors we don't know about. And that's the normal, humble position to be in terms of facing a complex medical condition. But in this condition, different from every other, we have a very firm idea of what's wrong, and we're going to pursue it to the ends of the earth, even if the patient is telling us that really isn't something that's relevant to them. So I'm not trying to argue for a purely biological approach to these patients. That would be entirely wrong. But there's dangers of biological reductionism, seeing something on an fMRI scanner and saying, "Oh, we found the area for consciousness, or we found the area for sadness in the human brain." This is ridiculous. But there's also psychological reductionism, where you can take a risk factor like this and say that's all we need to think about. It's all we need to care about with these patients. So coming back to this idea of the symptom being, or the thing being something in and of itself, that what this book I feel does is it entirely subsumes this entity of a functional neurological symptom within something else. And it's almost saying, well, it doesn't matter about the symptom. We've got this other thing, which we know it is, and we're just going to concentrate on that. And that, I think that blocks interest of other people in the condition, because it allows people like neurologists and psychiatrists to say that, actually, we don't need to care about this condition because it's nothing to do with us. We're going to go and look after our real patients who have other things that this is something different. It also blocks treatment as well. So it blocks thinking about treatment in inventive ways. So it blocks, for example, physiotherapists being interested or being allowed to be interested in this condition, because if it's something which is psychological, then they have no business in treating these patients. And when they do treat them and make them better, or make them a bit better, then people say, well, you just got better because you're allowing the patient to save face in some way, that this was an unpopular diagnosis to have, so we've allowed you to save face by having a physical explanation. So to sum up, I think that it's important to realise that this is a diagnosis that can be made on the basis of positive symptoms and signs which have nothing to do with psychopathology. I accept that trauma in various forms is a strong risk factor for the development of these conditions. But I think there are many other risk factors as well. Having a neurological disease is a very strong risk factor for having this. 20% of people with neurological illness have this problem. And there are probably many other risk factors that we don't know about yet. And so being humble about it and thinking that it's probably just as complex as any other condition helps us, I think, to develop a more complex model of pathophysiology and also of treatment. Because the issue is that at the current time, we have one of the commonest diagnoses made in neurological outpatients where there isn't a single specialist service, there isn't a single sort of group of people saying, well, we want to own these patients, we want to look after them, we want to care for them. And it's allowing people in distress to be avoided by people like neurologists and psychiatrists. And then when they are offered treatment, they're offered treatment on a very specific model, which is that you have had a psychological trauma, and if you don't admit it, and you don't admit that it's relevant, then you're not allowed to have treatment. You're not going to have any other help from us. So I accept that some of what I've talked about is a simplistic interpretation of what Freud was saying, but I think it's important to recognise the problems that this causes and how we might move from there. Thanks very much.
Thank you, Mark. So next we have Stephanie Howlett, who runs a psychotherapy service for patients with functional neurological symptoms in Sheffield, particularly seizure patients or something.
No, all functional neurological symptoms,
okay.
Yes.
Thank you, Steph.
So I'll tell you a little bit about our service. It's a specialist psychotherapy service specifically for working with functional neurological symptoms, set up by a consultant neurologist, where we work in a very multidisciplinary way. The neurologist retains the case, we work together, they see them afterwards. There's no question that the psychotherapeutic work diverts the neurologists from their work, and we also work jointly with physiotherapists. I deal in stories, human stories, making those links. In the hours that I spend with people, we do make those links that Richard was saying can be so difficult to identify in the research setting. And I think that clinical experience, as Freud and Breuer found, is really vital in understanding what's going on with people. I've worked with hundreds of cases of functional neurological symptoms over the last 12 years, and I'm going to convince you of the relevance of this book through the gritty realities of the psychotherapy clinic. Are functional neurological symptoms caused by trauma? Yes, most of our patients have been severely and often multiply traumatised in horrendous ways. We hear about childhood abuse of every kind, adult physical and sexual assaults, accidents, tragic and multiple losses, people who discovered family suicides, members of the armed forces and emergency service who've witnessed terrible events and they're not expected to react. And increasingly we're seeing refugees and victims of torture. Often my weekly sessions where I triage the referrals can feel quite traumatic in themselves. Sometimes the causes are less obvious, and we need to remember, as Freud said, that the memories or emotions linked to the symptoms are repressed because they're intolerable to that particular patient in context. So in therapy, we try to help the patient to identify these, to express them emotionally, verbally, make meaning, and thereby diffuse them, as Freud suggested. So how do we make the link between the symptoms and the repressed emotions? I personally don't press my patients' heads. I do take a detailed history of their life and symptoms, and I look out for life events and circumstances that might have predisposed them to develop a pattern of repressing memories or hiding their feelings. I look for events or clusters of events in the year before the symptoms onset that might have been a trigger. I look particularly for what brings up or starts to bring up emotion in the session, changes in body language, and also the lack of emotion about things that should be absolutely devastating. Somebody asked about seeing symbolism in the symptoms. Regularly, I see it, but not always. So the woman that suffered from constriction in her throat and a painful twisting of her neck had found someone hanged in the stairwell. The symbolism can also be in the language used to describe the symptoms. So the woman who would collapse and lie pale and lifeless and said she felt like death when she came round, I wasn't surprised, had experienced a terrible sequence of tragic bereavements. Having identified the traumatic events and emotional conflicts, we work on them in therapy, encouraging people to stay with feelings arising in the session and to express them physically and verbally. We look at their beliefs about emotional expression and patterns of interpersonal relationships. We encourage people to open up to others, to reach out, to accept their human vulnerability, and changing these patterns is a key protective factor. So I'll illustrate this with a case. I could tell you dozens, but I haven't got time. Jess was a woman in her 30s who suffered frequent episodes where she'd lose awareness, collapse, and go rigid. These were unpredictable, but could sometimes be triggered by blue flashing lights and the smell of bonfires. We're starting to get clues. Also, episodes which she couldn't remember afterwards, sometimes triggered by sex with her husband, where she would fly into a violent rage and try to attack him. She was tense and volatile, prone to panic, and incensed initially about her referral for psychotherapy, and Freud refers to this in the book. A life history revealed that she had been in a minor car crash just before the onset of symptoms and trapped in a house fire prior to that. She also hinted at something earlier that she didn't want to talk about. Freud talks about excess tonic excitement that can manifest in nervousness and agitation, and the need then to build resilience in the patient before you can work with the trauma and emotions. And so with Jess, we did a lot of stabilisation work at first, using calming techniques and psychoeducation to help her to recognise and regulate her autonomic arousal. We were then able to process her experiences of the car crash and the house fire in a gentle step-by-step approach that enabled her to feel, to express, to verbalise the associated feelings and the body sensations that went with them and make meaning of her experiences. It was only after that that Jess said she wanted to work on the earlier event, which turned out to be a brutal, degrading, undisclosed gang rape when she was 13, of which she had only patchy memories. They'd threatened to kill her and her little sister if she ever told anyone, and this fear had stayed with her. Freud talks about there being a primary and secondary trauma, and often it's the secondary trauma that triggers the onset of the symptoms, and there's often a bigger primary trauma early on. So the gang rape was clearly the primary trauma, the others were the secondary traumas, and we worked on that for another 3 months. Her episode stopped, and at 6 months review she was still clear. So what does this illustrate? Freud talks of symptoms that result when the patient is in a state of paralysing fear or transformed consciousness, which he termed a hypnoid state, and I think is what we would nowadays call dissociation. When Jess was raped, she would have dissociated from the pain and horror of what was happening. That's why she couldn't remember all of it. The states of violent rage were clearly a form of flashback of that rape, a bodily and emotional reliving that had been split off and kept apart, out of normal awareness. Maybe the rigid states were also a bodily remembering of the pain and horror that she felt at that time. We know that when people have dissociated once, this often becomes the default pathway to deal with overwhelming emotions, and this had happened with the 2 later traumas. The symptoms could be triggered by trauma reminders, i.e. sexual contact, blue flashing lights, or the smell of smoke. So we can see that both the nature of the symptoms and the context in which they occurred were indications of the concealed emotions and memories. I agree that patients can sometimes become fixated on their symptoms, and that attention then perpetuates what's going on. And I think in a way that displaces the emotions that rightly go with the traumatic events. But I think you can see from what I've been describing that the approach that Freud and Breuer described in this book really gets to the heart of the causes of the symptoms. And it helps patients to develop more emotional understanding and resilience to deal with future challenges. To ignore these traumas and emotional issues and just focus on the symptoms, as my colleagues over here suggest, would do the patients a great disservice and ignore what may be their one opportunity to deal with the trauma and put things right. Thank you.
Thank you, Stephanie. So next we have Alan Carson, who's a psychiatrist from Edinburgh, and as I've alluded to in my talk, one of 2 people really, and John Stone, who's a collaborator and neurologist in Edinburgh, really brought this disorder back into sort of recognition and importance, and it's been part of the drive as to why we are now getting research and funding and patients being taken seriously and treated with respect like they hadn't been for many decades. So thank you, Alan, for coming today.
Thank you very much for the invite. I'm slightly nervous and apprehensive about this, but as Tim says, this is a field I've been fascinated by over the last 15 years. And it's maybe worth just saying a little bit about my background, because it has a lot of bearing on the way I think about the condition. I'm slightly unusual in that my higher training was partly conducted by a professor of neurology and partly a professor of psychiatry. And I'm probably one of the few people in the world who gets sent patients from start to finish of the patient journey. So I take secondary referrals from other neurologists being asked the question, is this the correct diagnosis? Is it a functional symptom? I see them through diagnosis, explanation, psychiatric treatment, and then psychotherapy. As a researcher, I've done a lot of epidemiology, enrolled over 2,000 patients into studies on this condition, but my primary interest is designing psychotherapy trials. I've conducted the largest psychotherapy trial to date in the literature, and in the middle of conducting one of the principal investigators of an even larger one. So I have this slight background, and this is why I get troubled by what we've heard from Richard and Steph. Steph closed by saying we were only interested in the symptoms and sort of implied we're trauma deniers. That is not the position we're putting forward. We are absolutely clear that trauma is a significant risk factor for this condition. So that side, put that to one side. But what we're hearing from Richard and Steph is a form of dualism. Now, they like to think they're the good guys in dualism. They call us the biological reductionists, but they're actually psychological reductionists. They're not wanting to look at the whole picture, and Mark's outlined in a very detailed fashion where that comes in. But what we're also hearing is a historical revisionism. And that's the point I want to start my talk on. Because amongst my other jobs, I also edit a scientific journal. It's a journal very close to my own heart. It's called the JNNP, the Journal of Neurology, Neurosurgery and Psychiatry. It was started across in Bloomsbury by Kinnear Wilson. And the idea was to bring a whole picture, the various skills from neurology and psychiatry together to patient understanding. And one of the things we face as journal editors is what's called citation amnesia. And citation amnesia is essentially a form of fraud, where people give scientific credit not to the discoverer of an idea, but to someone else downstream. One has to say usually American, because they've got more and bigger grants. But in this case, what we're seeing is massive citation amnesia towards Freud and Freud's ideas, and a complete lack of recognition of what went on before. The idea that trauma and traumatic events linked to the development of functional symptoms was far, far older than this. If you look historically, it was probably first described by Paracelsus. It was certainly clarified by Sydenham 150 years earlier. And in the epistle to Dr. Cole, he wrote about this quite explicitly. He also gave the first clinical description of malaria and came to comment that opiates would be good for pain control, and generally sent it off to his mate, Dr. Cole, with a, how's that? That's probably the single best medical paper ever written. But more importantly, about 10 years before Freud published, Paul Bliquet conducted the first systematic case control study in psychiatry. It's a seminal moment in the scientific literature. And he showed unequivocally, over about 500 patients, that trauma and sexual abuse in particular were linked to this condition. And that was available and known to Freud. So if we're going to say that this debate is about the relevance of traumatic experience, then that belongs to Briquet, because he is the person who put that squarely and fairly on the map. And to suggest that it's only Freud who made that relevant. Freud maybe popularized it, maybe took the credit for it, but it was Briquet who discovered it and described it. And if you're in doubt, and you can speak French, you can go and read the manuscript. It is one of the classic reads. So we're not denying that. We're saying it's there. It was already known. Which then leads you to think, well, what actually was new in the studies of hysteria? They are unequivocally beautifully written, as Rachel pointed out, and I really enjoyed. In some ways, it's almost reminiscent of somebody I looked up to and respected and admired, and that's Oliver Sacks. The case histories are fabulous, so we can put that on the side, there's no doubt. But a bit like Sacks, you've got to ask, well, what was actually new versus what was description? And I think when you think about what was new, it was particularly the idea of unconscious and repression. And that wasn't quite so much part of Briquet's ideas. Now, Richard then went on to use the model of PTSD. Now, the problem with PTSD as a model is that the memories aren't actually repressed. The memories are all too clear. What is repressed in PTSD is the associated emotion. And the therapy about PTSD is linking the repressed emotion to the unrepressed memory. It's actually the reverse of a Freudian idea. So if we're looking for PTSD as a model to support Freud, I'm afraid it's actually the exact opposite. I was then shocked. I wasn't surprised that they went for case material, but I was rather surprised that they went for case material involving sexual abuse. Now, even Freud's fans would have to say that sexual abuse was not his finest hour. The abandonment of the seduction theory caused untold harm and damage to patients who'd been sexually abused and led to the reality of their symptoms being denied for quite some considerable time after Freud's death. So it was a brave, if rather self-destructive move on their part to use these cases. So not only was it not something Freud brought into the literature, brought in by Paul Bouquet, but it was something that Freud actually took out of the literature, the actual notion of genuine sexual molestation in childhood, referring it to more of a fantasy level with his later models. So that was interesting. But the more important issue, in a sense, is this aspect of referral bias. That of course the patients Steph sees have been traumatised rather. That's the ones who are referred to her. That might have been a Freudian slip. That was something he's given to the literature that's worthwhile. Your average neurologist, in seeing somebody without any psychological distress or hint of previous trauma, refers them elsewhere or doesn't refer them on. So, I have no doubt that's her practice and her experience, and I'm sure she's doing a lot of good work. And that leads us on to the final point I'd want to make, which is if we are talking about psychodynamic theories, I think we have to look at the light of what was Freud's contribution. We're not asking, did Freud do something that was historically important and set us in a direction of travel? Everyone accepts that he had a major... Whoa! Is that the room getting upset? Everyone accepts that he made a major contribution. What we're saying is his contribution still relevant today? And even in the world of psychodynamic therapy, I would argue that you have to say, well, what was his contribution? And his contribution was really on the role of libidinal forces and the pleasure principle, if you like. The idea that we had a libidinal it in conflict with an I, and that was where the repression came from and the cause of psychic distress. Now, those of you who've been listening to me, and tempted not to shoot me already, will have noticed a slight Edinburgh burr to my voice. And like all chippy Scots who came down, I'm going to look to another chippy Edinburgh man who came down to London in the 1940s, Ronald Fairbairn, and really said publicly, Freud, I'm sorry, you've got it wrong. The drive is not a libidinal it. It's a desire to make attachment with other human beings. And the birth of object relations theory. Again, maybe more popularised by Melanie Klein. Citation amnesia has its effects. No one's ever heard of Fairbairn. I went to look him up in Wikipedia yesterday, and they were more interested in his flamboyant but largely irrelevant MP son. But he was the man who started that ball rolling. And if you speak to any modern psychodynamic practitioner practicing in this field now who's running trials, that is the sort of models they're interested in. We've moved on to attachment theory, the empirical support for it, the role of human relations, and we're not denying any of that. But if we're even wanting to look in the limited field of the sort of psychological treatments being practiced, and I suspect rather described by Steph, actually it's Fairbairn's legacy we're talking about, not Freud's. So Freud had his place. Trauma is clearly important, but wasn't Freud's discovery. And the consequence, the legacy, actually, is a harmful one in that it's equated all functional symptoms solely to the psychogenic model and created a barrier between patients and treatment, as Mark so eloquently described, and caused us to look only at one risk factor. We're reduced to thinking of stroke solely in terms of smoking and missing the possible 263 other risk factors that exist for stroke. So I'll stop at that point before anyone throws anything. Thank you for your attention.
Thank you. So we now have some time for some questions from the floor before each of the sides put their final arguments before we go to the vote. So, questions from the floor. For any of in general or aimed at specific speakers?
Slippages in the presentation of psychoanalysis and Freud that we've just had. First of all, yes, Bouquet did say sexual abuse. Freud never said there was no sexual abuse. He always said there was sexual abuse, but what he was looking for was a universal factor, something that all of us could be subjected to, so we all could become hysterical. We haven't all been sexually abused, but we all have sexual desires that are illicit, and it is those that are forbidden and therefore repressed, and those that come back to determine factors in our behaviour. Just say that, and then I'll say something about the trauma thing. Freud also always made a distinction that he was puzzled by and didn't think he resolved between what we saw of the soldier in World War I, which he continued to call traumatic neurosis, not hysteria. His question was, why are the symptoms the same? Why in hysteria do we get paralysis of a leg and we get it in traumatic neurosis, but not that they necessarily have the same etiology? I've got lots more I'd like to say.
Anyone want to, Alan? I think you got a mic.
Oh, can I use this? I'm sorry, don't worry about people. I need to switch it on. I don't dispute what you're saying about Freud on sexual abuse, but the point of the debate, I think it may be better to use that one. The point of the debate is about legacy, not what was said or happened in the time. And the legacy wasn't great, I think we have to acknowledge.
You can't have a legacy without getting the history right. I mean, legacy has to be something that's about an accurate history.
Well, I don't think there's any doubt that Freud abandoned the seduction theory.
No, he didn't. It is wrong. It's partially right and not completely right. He never denied the seduction theory. He said it wasn't the explanation. That's different.
There's quite a long paragraph in his last book where he says sexual abuse happens more than we expect it to. Mm-hmm. It doesn't go. It's a cause of neuroses, and in fact he widens the idea of sexual abuse to include abuse between siblings, which we don't normally consider, and it's just there. So he never abandoned the idea that sexual abuse is traumatic, causes psychological difficulties. It's there, but what he abandoned, as Juliet says, is the idea that it was the cause, the complete cause. That's all. I mean, so he never abandoned the idea of sexual abuse being a traumatic.
I think there's more than one way of reading these things. Is maybe what I'll say tactfully in response to that.
I'll send you the paragraph.
I'm not denying the paragraph there.
On your second point, I might perhaps reply. And just remind us all that this debate is about this book in particular, and obviously Freud's thinking and writing evolved considerably over his life, a very productive life. But in this book, obviously before the First World War, we didn't yet have the experience of shell shock, and so he didn't have time or the opportunity to write about that. And you're right, he does separate the two, but in this book he talks about traumatic hysteria, which he clearly does identify with everyday hysteria, because he says they have a trauma underlying it. That's, for me anyway, the major contribution of this book. It's certainly true what you say about Beyond the Pleasure Principle, but that's a much later work where much had changed in his thinking.
I accept that. Though, in fact, shell shock was earlier in the previous wars, but never mind, accept what you're saying about the book. That's completely true.
Questions from you?
I'm really glad to be here. It's great to hear you all talk. I actually have conversion disorder, and I would be interested to hear what you think the implications are for working with people with conversion disorder. And as a personal comment, I would say that my sister and I had for years kind of things that pointed for me towards having that condition, but no one in the medical profession for ages would take it on board. But you could kind of tell. Like we ended up in family therapy once, but no one told us why we were sitting in the room. So I'm interested in that, and actually it can be really liberating, I think, to have honesty from a medical professional or whoever. So yeah, just like to think about that really.
Well, I see many people who have functional neurological disorder, conversion disorder, and most of them have had a very long journey to receive a diagnosis, and that has nothing to do with people not knowing what the diagnosis is most of the time. Most of the time the diagnosis is known and is quite obvious to medical professionals that are seeing the patient. The problem is that they never tell people what's wrong. And they're not telling them what's wrong for a complicated set of reasons, part of which have to do with what we're talking about today, that the people seeing them feel that it's not their job, because what they've just diagnosed is a thing which is a psychiatric condition, and the people seeing the patients are usually neurologists, and they just feel, well, it's our job to pass them on somewhere. And then when somebody might go to see a psychiatrist, the psychiatrist says, you haven't got a psychiatric problem because you're not depressed, you're not anxious, you haven't got you're not psychotic. So there's a sort of a black hole which people with these symptoms fall down. And all that's needed really is a simple diagnostic explanation based on the things that let you make the diagnosis. So you have a functional neurological disorder because this weakness that you have does a particular thing on examination. This is what it is. And then we can talk about why that might have happened in a complex way, revealing individual risk factors in different people, revealing different strategies for treatment in different people. But the way it's often done is it's presented in the diagnosis is not at all, or it's presented in a ham-fisted way that this has happened to you because you're stressed. The person says, I'm not stressed, I say, yes you are, and it all ends badly. So it does require a fundamental shift in the way that doctors approach this condition. And that's really part of what's motivating me to push against some of the things, the ideas that previously have dominated this field.
Yeah, and I think that one of the reasons that often the neurologist hasn't explained it properly is that they've had nowhere to refer people on to treatment. So what do they do with them? Alan suggested earlier that the reason that I saw a lot of trauma was because the neurologist selected the patients with obvious trauma. I think it's partly in the way our neurologists explain the diagnosis. So they do explain that the limb or whatever isn't functioning, and they demonstrate how they know that. But they also just throw in the seed of saying often we find this in cases where people have had memories or feelings that have felt intolerable. And they don't say more than that, but people then just sort of pour out to the neurologist what's happened. And so I get that information before people even come to me. But then I get a lot more disclosures in the course of the therapy. And I think it's very helpful just to plant that seed at an early stage.
I see patients with conversion disorder in great numbers in my clinic, and though I am persuaded by the relevance of trauma, I don't really work with it, and that's for practical reasons. I don't have time in my clinic to spend the amount of time it would take to discover what the trauma is or to treat it. So, as Steph said, I will describe that as a framework, but in practice I don't have time, and consequently I can't say for sure whether treating the trauma really is better than treating it with physiotherapy or anything else, because I only do what I can in the clinic. But I think I feel confident that it is a wonderful way to treat it if you have time. But I nor anyone else, I think, has ever been able to prove that.
Any more questions?
So I'm a foreigner, so the first association that I had was like, what a mess is the health sector in this country. And in one of the positions, I think it was the first against, what I felt was that they were speaking more about lack of accountability within health sector professionals than actually about Freud and his work. And what and I'm more interested is in the first part. Before the debate, the last lady that spoke mentioned about that co-creative nature of the cases, that that make that seminal work. And if we put studies of hysteria or relevance of psychoanalytic practice in these days, like in 2015, I wonder what is the thought on co-creating ways of understanding interdisciplinary the new pathologies that are coming with the social shifts that are in society through technology, through violence, immigration, refugees. I particularly work with refugees in the jungle in Peru, not here. So I see a lot of things that are not explainable with current theory. So how do you take it forward?
I think that's the point that Mark and I are trying to make, is that we need new models to take on new things, and we need to be open to the fact that there's more than one explanation. And in this, it's like any other relatively common disorder, that there's a multitude of risk factors, and each of these different risk factors may open itself up to a specific form of therapeutic intervention. And it's only by looking wider and being prepared to accept there may be more than one explanation or more than one etiological factor that we'll start to find these things. So we're not saying we've got the definitive answer. What we're saying is there are plenty of clues for what is known in terms of scientific study to support the fact that there are roles for other mechanisms, and also that trauma isn't a sole explanation, and therefore we need to keep an open mind. And one of the problems is that we view that hysteria as being the last word, which some people clearly do, because I go to many meetings over setting up services where that is said publicly. People literally will say, we're not putting money into physiotherapy because they all need to have psychodynamic therapy. And you're saying, well, I'm not sure that's true, actually. There is actually clear evidence from clinical trials that physiotherapy is effective. There's clear evidence that cognitive behavioral therapy is effective. We don't actually have any evidence that psychodynamic therapy works. Now, if you ask my personal opinion, I happen to think it does, and would see it as part of an essential sort of package of available current treatments. But I would like to think that before I retire, there'll be further treatments, even than these three relatively simple and relatively crude treatments available, and I hope we'll have some more specifically targeted treatments based on mechanism and etiological understanding. So if we think of stroke, previously it was all about dealing with risk factors. Nowadays you actually stick a catheter right up into the cerebral artery and wheat the stroke out acutely, and that's rather effective. I think there may be more to learn once we understand the mechanisms. That's all I would say.
I think that's a really interesting question, and I think there's ways of co-creating the story with the patient and working together to understand what's going on. But I actually agree with Alan that we do need to look at multiple etiological causes. We need to work together as multidisciplinary teams. So in our service we have multidisciplinary case discussions on a regular basis. We try to work together with the physiotherapists. Freud himself used massage and warm baths. How holistic is that? And I would love to have a clinic where we could use massage and refer people on for different alternative therapies. We've actually started using acupuncture in our clinic for pain as well. So I think that is the ideal. I'm not saying that dealing with the trauma is the only thing, but I think it's a fundamental thing, and if the trauma's there, we need to acknowledge that to the patients and work with it. Many patients have said to me, your service is the only one that's told me like it really is. Now I understand.
I'm a psychiatrist, neuropsychiatrist, but I'm rather wondering, because some of the debate is around the book itself, and perhaps there's something about
the form of the book that we're missing here. Because what's striking is the way it's a co-authored book with Breuer and Freud, and there is the presentation of cases, but there's something of a development within it, and it's celebrated from one side, from analysis, as the beginnings of the talking cure and foundations of analysis, which have obviously been moved on, both in terms of trying to develop it as a science, as Freud tried to do, or in further ways. So, and as psychoanalysis as practice is slightly different. But also, then I think about, well, what about the kind of great 19th century texts of neurology, for instance, Gower's, and which are kind of updated, but I don't know if we go back and read Gower's books on the mimics of epilepsy, for instance, the borderlands of epilepsy, or even if people go back and read Parkinson, his original treatise, we kind of send students or medical students back to that. I am struck with the other day, a very intelligent SHO junior doctor I worked with was very interested in the role of carers and was noticing something in his assessments of epileptic seizures, functional symptoms. And I was very inclined to send him back to Anna O as a carer, as Rachel said. So I suppose but my question is, maybe is there something about the form of the book, the way it's written, co-authored, that actually rather mirrors something of the process of the discussion and the debate we're having here, that we're rather missing if we just take it simply as a treatment manual. But maybe I'm being too clever. Have I not directed that question? Maybe Richard or maybe the side four could comment on the book as a more of a developmental story or a debate story.
Yes, very much so, because also, as you say, I mean, the fact that it is a co-authored book very much echoes and responds to the sense that you get, particularly from Freud, of the patient's own invention. So there's always two sides and there's always a dialogue, and between Freud and Breuer hints at the tensions, and the tensions across the time as well that they were writing it and working on it and so on. And so thank you very much for adding that dimension, and also thank you for saying about Anna O as a carer, because when the previous person who asked a question was talking about new pathologies in relation to trauma and treatment and so on, that also made me think about how there's something about the very word trauma in English, which is perhaps too loud and too acute a word, and very much part of what Freud and Breuer were talking about was sort of everyday troubles, like sitting by the bedside night after night of a dying parent. And it took me back to what you said, Richard, about wandering into the supermarket and, oh, there's my abuser. Well, hang on, there might also be something about the supermarket in itself, which is not a trauma, but is an everyday, I mean, the sort of, well, the caricatures of the 1950s critiques of the sort of the zombie-like experience, which we could now translate into the new kinds of everyday pathology of the screens and phones and all those kinds of things. But there's sort of things that are kind of background to a culture, which sort of go without saying, but to another culture, to a later historical moment, seem very much like perhaps ways in which we might think about diagnosing the problems that that culture had or has. So I thought that was just an interesting link you made.
There is another word Freud uses, which is insult.
I'm just listening, and I'm aware that the title of the debate is our studies on hysteria. The book in particular, is this still relevant? And I think there's something that turns on the note of the relevance here. I don't think any of us would sort of say that what Freud wrote in that book is entirely accurate. Time has moved on. We're 120 years on from there. But I think the important thing was the fact that he noted short stories, he noted narrative, he mentioned trauma, he mentioned memories and symbolism, and all of that has informed the development of the subject, particularly with understanding of PTSD. I've just come today from a from a conference on post-traumatic growth in another part of London, and a lot of what I've heard here this afternoon is so relevant to what I was hearing this morning there. So I think, yes, I think that this is relevant, but only in as much, like any historical study, it informs where we are now. It's been a course direction, if you like.
I agree, and that would, outside the context of the knock-around, I feel very much of the same way, that there is clearly relevance of these ideas. It's just, I did say it, what I said before, but it's the way that a simplistic sort of understanding of that has been taken and then has been used to inform really quite a serious schism within medical practice, particularly within neurology, about the way that people with these sorts of symptoms are viewed and should be managed. And that's something which has affected thousands and thousands of lives in a rather negative way. I accept that that's probably a misinterpretation and a massive simplification of what Freud was saying, and a lack of appreciation that he was talking in a historical context and things have changed, but it still is something which has happened over time.
Just to say, I've got no problem at all with what you're saying, and that's what I was alluding to when I made my points, that it undoubtedly was an important sort of part of the story, and we recently published, as part of a book on landmark papers in neurology, where we had to choose the 10 key papers over the course of history on this topic. We included studies in hysteria, so no one's trying for a second to say that it doesn't have its place at the high table, if you like. But I think it's more about an understanding of the limitations, and the relevance today in some quarters where I go is that people think it is the last word, and many people think that of commissioning services, and many patients get highly offended by that, and there are far more patients find that idea, and I've studied this empirically, so as problematic, and don't want that to be part of there, or want there to be an understanding that's wider than that, than think it's of benefit. So no one's trying not to say it's not relevant to some people, and some patients for whom it's relevant will be very grateful indeed to having appropriate treatment for traumatic experiences. But there's a huge amount of patients who are actually severely damaged by having it implied that they must have suffered traumatic experiences when they haven't. And if we're going by single case studies, you can bring out just as long a list of people who've been very damaged. And I think that's all we're trying to say is it's had its time, it was an important block in history, but we need to be widening the net now.
I think we have widened the net. I don't know any services. Certainly our service wouldn't work only with this Freudian approach. We tend to be very integrative. But I think there is something about this sense that we've done a research study on our patients which shows that they have very emotionally repressive styles of dealing with emotions. And I think there's quite a lot in the literature about that. So there's something about these feelings that can't be expressed, the words that can't be spoken, that I think can be really fundamental to the treatment. And I think that's what I take from this book and what's inspired me.
We've heard trauma described as one of the risk factors involved, but I don't think we've heard much about the other multiple risks that you're saying could cause the condition. And I don't feel that I can form a final judgment on what you're saying until I've heard a bit more about what the other risks are that you are talking about.
Well, one of the primary risk factors is the experience of some unpleasant nociceptive symptom. So just an unpleasant and often amorphous and unclassifiable symptom in your body. And that can come from a range of minor pathology, physiological experience, or psychological experiences like the somatic symptoms of panic. And the way we self-assess this, there's quite a lot of experimental paradigm evidence that can be about trying to impose a personal nosology or taxonomy on it. So you have a sort of top-down attempt to understand what's happening in your body. So that if you look at risk factors just in a straightforward way, the experience of physical trauma, minor trauma, not psychologically scarring, but just having odd physical sensations is quite important. We know there's a major effect on attentional bias, so that the way one pays attention to one's body seems to be important. We know that there may be particular cognitive types that are predisposed, in fact, coming to very early judgment on minimal data seems to be important. So these are some of the factors that have been known. There's some other sort of more mechanistic ideas about endocrinological risks and things that are coming. But whenever anyone has attempted to look at it in terms of an understanding of psychological variables, and even I do fully accept what Richard's saying is that it is difficult, but we actually, Mark and I, were the external examiners on Tim's PhD, which was written on Richard's study, and it was only a tiny minority of patients. I may have the figures wrong, Tim might want to correct me, but I think it was something like 27 patients out of 400 they looked at where they managed to find these factors and that clear-cut story. And again, please correct me if that's a misreading of the numbers. I'm going from memory. And the point I'm just making is I'm really quite interested and quite open-minded about what was going on in the other 300 or 400 odd patients. Is that a misreading of your study?
Yeah, I'm happy to correct you on that. That's a gross misreading of the study. We found it in about 2/3 of the patients. On the other points of the risk factors, firstly I would say that Freud discusses other risk factors in this book. There's a kind of a discussion, then he talks about many of the other theories about what factors might predispose you to develop hysteria. Hypnoid states, dissociative tendency, tendency to suggestibility. These are psychological terms, but obviously he had an eye to biological rendering for all of these as well. With regard to the point about minor trauma, I think that's an interesting one, and it's true that there have been many associations found, but it's difficult to call any of these things risk factors because we only know about them afterwards. We only know that patients who've been diagnosed with hysteria now have this feature, so we don't really know that they had this tendency before, we only know they've got it now. So yes, they do attend to their body in an abnormal way, but maybe that's because they've now got hysteria. So the point about minor physical trauma, again, that's another thing that has been described in your study, but I put it to you that a minor physical trauma can be a trauma if it is in a frightening context, yet again. If, for example, and I'm sure this will be familiar to all of us here, anyway, on the stage, if you have a minor trauma and someone around you says, I think maybe this is the sign of something extremely serious, which is a common description that patients will come to me with. I had this pain just in my chest, and then someone said, I think you're having a heart attack, and that's when all my symptoms started. Yes, the pain was minor, but the interpretation was catastrophic. So it can be a trauma, however minor the pain was.
But that's rather different from the type of trauma that you and Steph have been talking about.
Not necessarily. I think it's a full range.
Any more questions from the floor? Got time for one or two more.
I just want to say something about, you mentioned CBT, I have no experience, but the only experience I have is that I've seen 5 different patients as a psychoanalytic psychotherapist who were referred for CBT to psychiatrists who treated them. They felt better. Sorry? The patient said that they felt happy. This is their words. They felt happy. They felt they're cured, and they left the hospital where they were treated. 6 months down the line, they had a relapse, went back to the same psychiatrist. One of them was treated again, 6 to 8 sessions. Again, they felt better, but the efficacy seemed to be going sort of down. Eventually, the same psychiatrist, who was very open to other modes of therapy, referred them to psychoanalytic psychotherapy, and they came to the clinic where I work, and they're still in therapy. And there's been a change, very slightly, but there's a movement there. And so I've heard so many cases, and other 3 as well. I saw 5 of them. Went for that, thought they were cured, very happy, left, and then again had relapse, and then were referred. So I don't know about it myself, but because you mentioned, and I have met one person who said she had transactional analysis, talked, and then nothing happened, and then went for CBT, and she's cured. So I've had, she's not a patient now. She's training to be a CBT.
Well, I wouldn't dispute what you're saying. That psychological treatments have a limited efficacy. They don't cure everyone. And when you look at this psychotherapy literature, actually, it really doesn't seem to matter what the treatment is. If you analyse the variance, you have far more explanatory power between therapists than between therapeutic models. Now, that's a relatively uncomfortable fact for the psychotherapy community as a whole, and I'm not just talking about psychoanalysts, and a lot of them feel uncomfortable about that, but it is undoubtedly the case, and that has been shown in numerous studies, and there's no serious scientific debate about it. Now, we can talk about the limitations of outcome measures, etc., as much as we like, but the bottom of the line comes in this day and age that there has to come a point where people put their money where their mouth is and do empiric trials. And there are some very good trials of psychodynamic treatment. I'm not aware of any trials of psychoanalytic treatment in its own right, and maybe somebody will correct me on that. But ultimately you have to be prepared, I think, in this day and age to do that. And I think the days are gone now where people can get by saying it works because I know it works. And so, that's where I stand. So I don't think CBT cures everyone. That's the whole point I'm making, is that I think psychological treatments, as currently practiced, are effective for a range of patients. But the reality probably is that there are effective therapists rather than effective psychological treatment models, if we're being truthful about it. And they should definitely be part of any holistic service for functional symptoms. But it's that very fact that they don't cure everyone and they don't seem to work for everyone. And most importantly of all, and somebody at the beginning had asked about treatments in MS, I'm also involved in psychotherapy trials for other neurological disorders, including MS. They're actually quite poorly tolerated as well by a lot of people. There's a lot of people who simply cannot comply with the psychological therapy. And we have to be saying, well, what's that about? It's not just enough to blame the patient. We sometimes have to blame the therapy and blame the sort of treatment pathways we have and say, well, what are we going to do differently for that group? So, yeah, I wouldn't dispute that.
I'd also just say this concept of cure, and it's a concept that goes through most of medicine, and it's a myth that there's very few things that medicine cures, and this is certainly not one of them. So it doesn't surprise me that people get worse again after treatment. And I would never say to somebody, I'm going to cure you of your problem. I'm going to say, well, we're going to try some things which hopefully will improve the situation, maybe quite a lot, but they're not going to magically get rid of it. And what you're describing there really is what a proper service might be, that it might have access to a range of different treatments which you can choose from for particular people. And over time, with more evidence to get better and better at choosing the best treatment for a particular patient first of all. But that's the whole idea of having a palette of treatments that you can refer people to according to their needs.
Got one final question, sorry. Did you want to say something? No. Final question before we round up. Yeah,
well, it was a comment on the previous round of discussions about where we seem to be getting to the point where we were wondering, well, can there be such a thing as sort of trauma that's not psychological, but can it be actually sort of physical, and is it in the body and so on? And I think for me that touches upon what is sort of, in a way, the least satisfactory part of this afternoon's discussion, which is, that it seems to be sort of a massive turf war where we're never quite sure really what applies where. So this term of psyche or body, or where is it? Is it neurology? Is it psychiatry? Is it psychotherapy? And is the psyche, what is that anyway? And then in some ways I think Freud himself was quite a naive philosopher and sort of tried to sort of make it out as though it wasn't really a philosophical problem. And I think that's why, rather than sort of pretending to ourselves, well, if we could only get the next cutting-edge treatment or next cutting-edge research model or something, no, much better actually to really pore over some old philosophical textbooks and read a lot of Plato or Plotinus or something, and really try to understand what we're talking about when we begin to talk about body and mind, because we're all converting all the time. I mean, when we cry, those are clearly physical. We can count the tears, we can analyse the chemistry of the tears, but it's an emotional response, presumably. It's not something that is organic. So I think until we start try and clarify some of these sort of underlying conceptual issues, that actually we're just going to go around in the circles we've been going around in for the last hour, very entertainingly, by the way.
I should say we did have a conference, The Meaning of Crying, in 2003.
Can I just say, I think that the point about the studies of hysteria and what Freud does say is quite philosophical, and it does sum up this notion of a whole story of suffering. So in that you do have story and you do have suffering, and it is looking at the kind of the psyche and the soma together. So I do think that kind of has been said, but kind of divisioned, and I think it is about all of it. So, and you also said about alleviating some of the suffering, you can't cure it all. So,
quick responses before we move on to summing up.
Just going to say that of course that's a turf war as well between philosophers and doctors over who should treat this, and as you'll undoubtedly, I'm sure, know from, I'm assuming, a philosophical background, that can't express very forcibly that this was for philosophers only and doctors should keep out. But the simple reality is very few patients are turning up at hospital asking for a metaphysician.
Yes, about whether it's physical trauma or emotional trauma, I think you shouldn't divide the two. Many of the patients have had some physical trauma, hospitalisation. There's a lot of iatrogenic damage that we see, and we have patients who get referred from one speciality to another, having more and more tests. Every test is traumatic. They're waiting for the time when they're going to be diagnosed with this awful disease, and that is trauma in itself. So I think there's no real mind-body division, and we shouldn't be looking at that either in these risk factors.
Okay, thank you. So we'll just quickly have a brief summary by the proposers for each of the sides of the debate before we then take a vote. So 1 to 2 minutes for Richard and then for Mark.
Okay, thanks, Tim. So I just want to reiterate, the motion here is about this book. It's not about hysteria, it's not about Freud or psychoanalysis, it is about this book. And in this book, there has been much that has been attributed to it by our opponents in this debate, which is simply misplaced. This book doesn't really talk about the unconscious. It doesn't really talk about sexual trauma in great detail. It talks about a model of trauma that is concealed, not by being repressed in the sense of hidden, but just in the sense of being avoided. And what we have described as how, if you're careful enough, you can find these traumas most of the time. a modest claim, the kind of claim that Freud makes in this book. He himself is circumspect. He doesn't say this applies in every case. He says all the cases are complicated and mixed. We, I'm sure, think every case is complicated and mixed, and we've been parodied by our opponents here as insisting that everyone has some repressed trauma, which of course we wouldn't do, and I'm sure Freud would not have done. Let's remember, all he did to get his patients to remember was to tell them, you really can remember if you try. So talk of mechanism here, talk of biology, and that we might be dualist, is misplaced and misleading. Freud was not a dualist. We are not dualists. He aspired that we would all understand this in complicated, multifactorial terms. And rendering it in any other way is doing a disservice, both to us and to this book.
So I may not be able to completely argue against you on all of that. I would just like to come back to one point, which is about the thing with, I mean, this book is about hysteria, and even if we want to translate that, we're going to call it conversion disorder, or we're going to call it functional neurological disorder, we're talking about a thing which is a thing in and of itself. And while I accept that there may be important risk factors in the shape of trauma, this is not trauma. It is a thing in and of itself, and although trauma may be an important part and a mediator of what's going on, we need to respect the fact that it is something in its own right. Because if we don't do that, then we alienate a whole group of people who have not had trauma. And we also stop looking for other causes and other ways of treating people. And I think, and it also stops us engaging as different groups of physicians, different groups of therapists, in what is an enormous public health problem. There was a study recently saying that the costs of medically unexplained symptoms, which is yet another euphemism, in people of working age in England per year, is about £18 billion. So that's more than dementia care. And I don't think I've seen yet a documentary on Radio 4 or a charity campaign collecting money for people with conversion disorder or functional disorder. And there may never be if they remain in such a stigmatised group. Thank you.
So thank you. So what we'll now do is if we can put hands up for supporting the motion, so that Freud and Freud's studies on hysteria is still highly relevant to the disorders we now know today. So we have some counters, so if people could put their hands up and... right. You're not allowed. So I've got... So Glenn, how many do we have? 18? Okay, and hands up for those against the motion. Bit easier. Two hands from one person, that's great. Five on the left and one person counting themselves as two on the right. So, okay. And any abstentions? 4. Okay. Well, I think the motion carried quite convincingly, but perhaps no surprise given where we are today. But I'd like to thank all the speakers who've given up their time for this. I'd like to thank them. I'd also like to thank the Freud Museum for hosting this, and thank you most importantly to yourselves for contributing to a fascinating debate. So thank you very much.